I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I am thrilled to welcome Dr. Katherine Eubanks, a world authority on ruptures and repairs in the Therapeutic Alliance. In our conversation, we discuss what's therapeutic about the Therapeutic Alliance, what are ruptures and repairs, alliance-focused training, types of ruptures, and much more. Please leave a comment below, and if you enjoy this conversation, it'd be appreciated if you hit the like button and subscribe to the channel. This episode begins with my guest responding to my question about how she got into studying alliance ruptures and repairs. Let's jump in.
So I first encountered the idea of ruptures and Chris Moran and Jeremy Safran's work on it when I was in graduate school. My mentor, Marv Goldfried, had us read it, and I can't remember, were we reading it in class or as part of his research lab or both, but I definitely was exposed to the ideas. And actually, my classmate, my lab mate, Lisa Brickell, focused on it for her dissertation. And we were collecting our data together, so we were collaborating a lot on pieces of the project. So I was definitely aware of it, thinking about it. But what really got me into working on it was I did my internship at what was then called Beth Israel Medical Center. So my year-long training in a hospital setting, like last step before getting the PhD. And Chris was the chief psychologist there. So all the interns had saw one case that he supervised in a group supervision, doing this, what I now know is called alliance-focused training. And then I also did an elective research rotation with him where I worked on a project. And during the course of my internship, Chris said, "Oh, I have a position for a postdoc." And I applied and I became his postdoc and basically just haven't stopped collaborating with him on research on ruptures and repairs.
Do you remember what that was like that first alliance-focused training with that specific client?
Yeah.
Could you talk a little about that?
Yes. So, I mean, a few things. Definitely, I think there were things about the approach that I actually have a memory. This is making me remember the first time I think it was the first time I saw Chris and Jeremy present at a conference. And so this was before internship, I'm pretty sure, if I'm getting my dates right. And I remember they presented some clinical material and I couldn't follow like what was going on in the example. I don't know why, but it's funny, like looking back, because I remember sort of like, okay, something's going on here, but I'm not totally sure what they're talking about. And then now, like full circle, like all I do is watch videos and like develop measures to identify these things that are happening. So it's sort of funny. But my first case, I remember was very challenging. I remember doing a role play in supervision with Chris where I was playing my patient, and that it was incredibly helpful to try to imagine my patient and see. It's like I could see myself through my patient's eyes. I had this sense of like, oh, I can see her coming a mile off. And she thinks she's going to get me to open up, but no, she's not. And it just gave me this like different visceral sense, maybe, of what my patient was experiencing, which I found really helpful. And then
it's like really intense empathy.
Yeah. I mean, of course, I can't be sure I actually know how she felt, but it was like this kind of paradigm shift in my head of what might have been going on between us. And then we were doing a treatment. It was supposed to be 30 sessions. And my patient dropped out at session 24. And I remember by that point, I think I definitely applied, maybe had accepted the postdoc position. And I was like, oh no, is he going to want me as a postdoc if my patient dropped out? But you know, that's part of the process. That's part of the experience. And even with her, I mean, it was a complicated dropout because in a way I felt disappointed, you know, that she left, but it was also her sort of asserting herself, which actually was something that would like be good for her, given sort of how I was understanding what was going on for her. So it was like, wow, this stuff is so complex and interesting. And yeah, I've just, I don't know, once I got into it, I wanted to stick with it.
And was at that point, were they looking specifically at the rupture parts of the alliance?
Oh yes, so they were studying ruptures and had developed some they have this sort of post-session questionnaire that includes several different indices, questions of basically like, was there any tension, difficulty, disagreement between you and your therapist for the patient to fill out, and between you and your patient for the therapist to fill out. And actually, one of the first things I did as a postdoc was help with pulling together a publication analyzing a big set of data that they got with this self-report questionnaire. So they had had done well using those, but they also wanted to supplement it with more measures, including an observer-based measure. And that's how I ended up working on the Rupture Resolution Rating System, or 3RS. Is it was also an early project during my postdoc. Chris and Jeremy were like, "Hey, can you work on an observer-based measure here?" And sort of gave me some materials to get me started.
Right. Yeah. Let's give this to the postdoc. This really difficult, laborious, tedious task.
Well, yeah, but maybe it also, I don't know. Like if you had told me then that I would still be working on this measure years and years later, that might have been daunting. But yeah, it's really interesting. It's never going to be perfect, so I have to accept that. My own issue with perfectionism is part of why I think I like this rupture work. It's like, instead of denying, avoiding, being scared of the messiness and the mistakes, like, let's just lean into it, and this can be helpful, useful, opportunity. So I think that's part of why this stuff resonates with me.
Before we get too far into it,
yeah,
we should probably spend 90 seconds on what the Therapeutic Alliance is.
So the short version, what a lot of people use in our field is Borden's conceptualization. So Borden talked about the patient and therapist need to agree on the goals of therapy. They need to be able to collaborate on the tasks of therapy. And there needs to be a bond between them, like mutual respect and empathy. So we can think of the alliances, the working alliances, being those three pieces.
Okay, so this is one of the things I've been maybe trying to lean a little more into. I did a few weeks ago, I had Paul Hewitt on here. I don't know if you know Paul. Yeah.
I know the name,
he does a lot of perfectionism stuff. He's like perfectionism has like some really great, like particularly like group psychodynamic treatments for perfectionism. But we were sort of, one of the things that came up in my conversation with him is, what is I'm going to use the phrase healing power. That might not be the perfect phrase, of the Therapeutic Alliance, above and beyond how I think a lot of times we think about it. Like, I think like the importance of the alliance has sort of become cliche in the field, particularly in training. And it's sort of like, yeah, I have to have a good relationship with my client or else they're not going to like me and this isn't going to work. Right. I think that's sort of I think if we did an observational coding of how it's talked about in a lot of contexts, they'd be like, that would be it, sort of necessary, but not sufficient, blah, blah, blah. Right. But I think that there's a lot more in terms of, for folks who are really, thoughtful about this, how the alliance works, how it's helpful. And I was kind of curious what your thoughts are about that.
Yeah. I mean, I think, so one thing that I find really helpful, so Chris and Jeremy's seminal book that was published in 2000 is called Negotiating the Therapeutic Alliance. And that word negotiating is such a great word, because it really captures how this is not like a box you check off. Okay, alliance good, let's go forward. It's a process that's always unfolding, and it's two people. It's not just one person. It's the dyad, kind of always figuring out, okay, I can give you this much, not that much. Here are my boundaries. Here are your boundaries. Trying to work together to develop a shared understanding of what's going on and to collaborate. So I think that's a really helpful word. And then I also think a lot about the alliance as a having a potential for providing or facilitating a corrective experience. So especially for, I mean, this may vary depending on what patients are coming in with or what they're working on, but especially if something about relationships and your experience of relationships is part of what you want to work on in therapy, like here's a relationship. And it's this rich opportunity to try navigating a relationship in a slightly different way. What happens, maybe getting a different response, and maybe getting a different or expanded understanding of how you can be in relation to another person.
Got it. So I think this leads right then into your work on ruptures and repairs. And how do you, just to sort of, again, big picture, do you does it make sense to just sort of like start out with ruptures or sort of doing both at the same time? What do you think?
Oh, for rupture and repair? Yeah. I mean,
yeah,
ruptures, so I can like define it very briefly, but then in another way, like so much of my research is trying to define it. So we can go on as long as you want about that. Like in a brief way, okay, if the alliance is, we're collaborating, we agree, we have some shared sense of where we're going, we have some kind of trust and, bond, then if we've got any problems in any of those areas, we've got any difficulties in any of those areas, we could think of those as ruptures. We can also think about it as, look, everybody's got needs for agency and communion. That's a really helpful one. Like we want to like assert ourselves and do our thing, and we want to connect to other people. And if you've got those different needs and then two people with those needs, they're going to inevitably kind of bump into each other. That's just going to happen with two people interacting. So some kind of rupture thing is going to happen at some point. And we found it helpful to talk about these using some terms that Heather Harper first used in her dissertation to talk about ruptures in terms of confrontation and withdrawal. So confrontation might be the first thing that comes to mind when you hear the word rupture. We're butting heads, we're moving against each other or moving against the work of therapy. And then withdrawal, we're moving away, avoiding, trying to change the subject, trying to distance from each other or the work of therapy. In our work, to me, both when I'm trying to identify things from a research perspective or when I'm trying to identify things as a clinician, I want to be aware of not just the big obvious ruptures, but the really tiny little micro moments that could become something potentially. That's where I have more room to intervene. So I'll use the word rupture to talk about the little moments as well as the big moments. That sometimes throws people because they might even say like, oh, ruptures don't happen to me, because they're thinking of some big conflagration. But I'm like, no, even those little weird moments or little awkward moments, those are something. And I do think about those in terms of little movements of confrontation and withdrawal.
Well, that was exactly what I was going to ask you, which is how big does that confrontation or withdrawal have to be in order for it to be classified as a rupture?
Yeah, I would call all of it that, and then then we can rate it's more or less intense or severe, or we can have some kind of gradient. But I think they're all important, and if we just wait for the really big ones to pay attention or take action, we may have missed our opportunity.
Could you give us an example of a confrontation is probably easier to do on this medium because withdrawals might be more, well, I think it both would be, but like, what would be like, so on the 3RS, you have it's a 1 to 5 scale, right? So it's like 1 is like nothing up to 5, which is a bunch. So like, I'm curious what a like confrontation rupture that's a 2 would look like, and what's a confrontation rupture that's a 5?
So, that's a good question. So, let me think. Like a 2 might be, I'm not sure about the homework versus that homework made no sense. I don't, I didn't do it. It just made no sense to do that.
Okay. Right. And then like, what about if we did the same thing for a withdrawal kind of a rupture? And I'm sort of thinking that a lot of times like a small withdrawal rupture is going to be, I mean, naturally it's going to be a passive thing, right? So it might just be like me not responding much, or like,
yes,
okay.
though there is an active form of withdrawal. So that would be like you're trying to get somebody to talk about something, and it's like, well, yeah, that it is tough what's going on at work. But it reminded me of something that happened with my neighbor, and then I met them in the hall, and they were talking about and blah 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 blah, and I just changed the subject.
Oh.
So I could be talking a lot, but I'm changing the subject, or I'm telling you a random story that doesn't seem to go anywhere, or I'm using a lot of jargony, intellectualized language. I'm moving away from the work.
Mm-hmm.
We see a lot of that.
So what would a 5 look like? Because I'm sort of thinking, like, as you're saying this, I'm thinking about like, I was thinking in my head, like a 5 or 4 or 5 or whatever would be like me shutting down or putting up a wall. But then I was also thinking, if I really do that in a kind of an overt way, that's, I don't know, is that confrontation?
I think this is a part of the challenge is if I think hard enough about it, like I can almost think my way from any withdrawal to seeing it as a confrontation, and vice versa, right? So like, yeah, like I can move away in a way that there's some kind of like hostile or controlling quality to it.
Right. I'm thinking like cross my arms,
Mm-hmm.
I lean back, I whatever, right? Or I could like in a way that is, it's kind of aggressive.
Mm-hmm.
I mean, there's nothing, right? Because
Mm-hmm.
like passive is like, it's sort of like, I don't want you to notice me. I want to sort of shrink away and be, but like, if I do have those big gestures, that is sort of like, I want you to see this, which does feel more aggressive.
Yeah. And in coding, we might handle those kind of situations. I mean, first, you can code one thing as being multiple things. So you could consider a moment of having both elements of confrontation and withdrawal. Also, it can have elements of both rupture and repair in the same moment. And sometimes just in terms like with coding, we have to reach reliability. So we kind of draw a limit as to how far we'll infer. We'll sort of like, well, maybe it could be this, and this, but we have to keep it a little bit more at like, not exactly the surface, but pretty close to the surface level. But clinically, I think it's super helpful to be thinking about how these things can all be combined. I mean, really, the withdrawal confrontation distinction, it's like a heuristic that's useful, but nothing's that simple in real life, right? Everything is a mix of a lot of things.
Mm-hmm. So what would be an example of like a 5 withdrawal?
It could be, and we're usually coding in like 5-minute segments, right? So a 5-minute segment, if I started telling a random story and I spent the whole 5 minutes telling it, I'd give a 5 for withdrawal for that 5-minute segment, right? Like the whole 5 minutes was dominated by withdrawal.
It is clear based on this session and what I've seen of perhaps other sessions that this is a filibuster very intentionally, but he's trying to get away with it. He's not trying to, intentional. Okay.
We're not making a judgment about how conscious or deliberate it is. It's just, this is what we see is movement away. Okay. That's salient and, intense. Or it could be the person goes silent, right? It could be either extreme, but they're both not collaborating with the process.
And while you were saying that, I realized we probably should say this. So there's the one that I had your old one and I guess maybe original one in my files. And then when I was preparing for this, I was like, I found the 2022 one. Mm-hmm. Is that the most recent one? Okay. So it's a lovely manual, lots of examples, lots of nuance. So I will link to that in the show notes for anybody who's interested, though it's free, at least as far as I can tell. I don't think I was doing anything I wasn't supposed to do.
That's our intention. We want it to be accessible for people.
Great. But it is worth, I think, highlighting that when you all do this coding that you take the session, you divide it into 5-minute chunks, and then you code each 5-minute chunk on the various indices. Okay. Okay. So what does it look like when the two happen simultaneously? Oh, well, I guess we haven't gotten to repairs yet. So I
Yeah.
guess we should briefly talk about repairs.
Well, repairs is, repairing whatever happened, right? So if they couldn't agree, then maybe they reach an agreement. Or if there was a sense of disconnection, now they come back to being more connected and collaborating again. With the coding system, we do have a way of rating sort of how much things were repaired, but we also are rating repair attempts. So it may be somebody's trying to repair something, and we're interested in that, like their efforts to repair. Whether they're successful or not is like a separate determination. So we have descriptions of different strategies someone may use to try to repair. Initially, we thought of them as therapist strategies, but in this 2022 revision, one of the things we were focused on is realizing, both patients and therapists rupture and repair. So you can rate both of them on ruptures and repairs.
So could you, so in the manual, there's a bunch of different sort of repair strategies. Could you give us, you don't go through all of them, but some examples of those?
Yeah. So one set of them we think of as sort of repairs where you're kind of focusing on the task. So this could be like there was something unclear about a homework assignment. And so then it would usually probably be the therapist explains the homework assignment, in response to, I didn't understand it or I didn't see the point. And then the therapist is like, oh, well, this is why I asked you to do it. I thought it'd be helpful for this reason, da, 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 da. So that could be a simple repair strategy. Then there's also repair strategies that are more about saying, hey, something's going on. Let's explore what's happening between us and really getting into exploring the rupture and what's happening for you, what's happening for me, exploring that, validating that. They could include the therapist self-disclosing their experience of the rupture. So that's where a lot of like Chris and Jeremy's rupture repair work was really focused on kind of developing a model of that exploration of rupture.
So that I'll jump to this then. So because they did some task analysis, well, you were part of it too, some task analysis work, sort of like looking at what this repair process looks like. I was wondering if you could talk a little bit about that.
So the first task analysis predated my joining the team, but the first one was looking at this exploration and this idea of, you sort of recognize that a rupture is happening, and then kind of invite this exploration of it, really trying to get into the experience, the here and now. Don't jump yet to trying to interpret or link it to somebody's, past or anything, but really what's happening between us, really trying to get into the details of that, recognizing that doing that can be hard. So be on the lookout for movements away, kind of withdrawals within that exploration, try to come back to it. And the idea being that with withdrawal, you would probably be identifying some kind of underlying need that the patient needs to assert, something they've been holding back or moving away from. You want to kind of help them come forward with it and assert it more directly. And for confrontation, the idea being there may be some underlying like hurt or vulnerability that underlies the attack or the hostility or whatever you're seeing on the surface. And you want to help somebody sort of access that. And the hope is that then all of this is facilitating a corrective experience. So that's kind of the model for exploring a rupture. More recently, we did a task analysis looking at the strategies that are more about focusing on the task. And we basically in the data we were looking at, we found that the therapist used all kinds of different things. There wasn't sort of a clear do this, then this, then this. It was just like a lot of strategies, and they would employ different ones sort of depending on the patient and the situation. But things like explaining the task, or if we got to move it away from the task, it's sort of like, well, let's come back to the task and focus on it again, giving a good rationale for it, things like that.
Okay, so there wasn't, and that was something that the process wasn't as consistently sequential,
right? And something that Chris and I are interested in doing is seeing so we've done this work on well, this is how you might explore, and here's ways you could kind of focus on the task. But what about that decision point? Like, which set of strategies to go towards? Do I explore? Do I not? Do I focus on the task or do I not? And so something we're planning to do and thinking about is, could we have one big model that like sort of brought it all together and kind of helped somebody in thinking about, I think the question of when to explore and when not is a really interesting one, because you can't explore every little rupture-y thing you see, or you'll never do anything else. So how, like, I'd love us to have guidance for like, when should you go, wait, now I really need to explore this, versus maybe I let it go for a minute, or I wait and see, or that kind of thing.
So that the exploration is going to be typically a more, a bigger lift in the therapeutic context.
Yeah, I guess that's fair. I mean, it may also depend on the kind of therapy you're doing, or sort of what your typical session looks like how much it will differ from what you're normally doing, let's say.
Yeah. So, because I think we're talking this, language, and I feel like I'm following you, but I sort of feel like in podcast land, if I was listening to this while I was doing the dishes, I might get a little bit lost.
Sure.
So I'm curious if we could so like if I was a client and I said to you, Dr. Eubanks, I didn't do the homework this week. I kind of didn't feel like it fit what I needed.
Yeah.
Like, what would that look like? Like, what would your response look like if you were going to do more exploration versus more, task focused? Is that a reasonable question?
Yeah, that is. I think the first move either way would probably be, oh, can you tell me more about that? And then if I'm going the exploration route, I would be seeing that as like, this is something I really want to dig into and I want us to really focus on. Whereas the other route might be, if there's some kind of, I didn't think it fit my experience. And then I'm like, oh, well, if I gave a rationale, well, this is what made me think of this assignment. And then if you were like, oh, okay, that makes sense, then I'd be like, okay, fine. And we'd move on. Versus the exploration might be, even if you said, okay, fine, I might be like, but wait, I think we need to talk about this some more. This, like maybe if it was a pattern that had happened a few times, so I felt like there's something more going on here than just this particular assignment didn't make sense. Or if something about sort of how I'm understanding you and what we're working on, like, we need to dig in here for a minute.
So in that moment, as the therapist, you're sort of using your clinical judgment to say, okay, is this something that, I probably just didn't do such a hot job explaining it at the outset, and I just need to explain it a little better and get their reaction, and assuming their reaction is somewhat agreeable and, considering their larger sort of presentation and whatever, great. Well, this will be a 30-second, 60-second sort of an interaction to get for that repair to happen. But then there could be other situations where, okay, we've done this homework. This is the third week in a row with this homework thing. He came in here asking for this sort of work and he's not doing it. And this is consistent with other things he's doing or not doing. So this might be the whole session, but we're going in.
Yeah. The way you laid that out was beautiful. Yes. And add to, okay. And I might make the wrong call, right? Like I might decide we need to explore this, and then we kind of don't get anywhere, and I realize I should have let that go. Or I may think, oh, we're fine. And then it, important stuff often comes back, right? So then it's like, oh, that was the third time. Oh, now here we're at the fourth time. Okay, Katherine, come on. We need to talk about this.
Yeah. And that's exactly what I was thinking about, which was like, that the first time you do if you do homework, like the first time you do it, that it's very common for it to be a little bit of a dud, and like oftentimes it's like, oh shit, we only have 3 minutes left. I better do it now. And so, but then if, it's repeated or whatever, that's when you might dig deeper into it.
Exactly.
Yeah. So okay. So that totally makes sense. Yeah, as I was reading the task analysis that you did, like we did a task analysis, and it was like, but it was like solely focusing on the client. And I was like, in reading, I was like, man, doing with both the client and the therapist and this process unfolding over time, I was like, man, that's doing a task analysis on hard mode. Like, I was like, that's really hard because it's hard. I mean, it's hard. What we did was hard.
Yeah,
and so,
it's hard, but I've always been really interested in the experience of the therapist and the person of the therapist. And I find it really exciting because there's so much, I guess, training implications, right? When we identify the therapist's role and what about the therapist, how can we maybe train or support therapists to navigate situations more effectively? I just think that's really interesting.
And I know you do a lot of training, so why don't we just jump right in there? So could you give sort of a broad overview of the training that you've been doing?
So alliance-focused training, and the way we've primarily done it is as a form of group supervision or group consultation. So a group of, maybe 4 or 5 trainees, and we've been doing it with 2 co-leaders. We found it's a really nice way to do it. And
how big are the groups?
So if we've got like 4 or 5 trainees plus 2 co-leaders, let's say.
Oh, 4. Okay,
yeah.
Got it.
So ideally, everybody's videotaping their therapy sessions and can bring session video, but sometimes people are in places where that's not possible. So if you can't bring video, then we might ask you to, tell us in as rich a way as you can. And we use a lot of role plays. So I guess the way a meeting might look is we'll start with a mindfulness exercise, because we think mindfulness really fosters the right kind of headspace for doing this work, where you're really open and curious and non-judgmental and self-compassionate. So we'll start with that, and then figure out who's going to present. They'll show video or describe a challenging moment. So it's not a place to come and show off about, it's not your highlight reel time. It's bring the place where you felt stuck, a place that was really hard. And so this is where it's really important that the space feels like a safe place to bring these moments. So it's really important that the co-leaders foster a safe environment with good group cohesion. So bring that difficult moment, and we'll try to kind of, so what's hard for you? Like, what's the place you're getting stuck? What's your struggle, for the therapist to identify that? And then we'll look for an opportunity to do some kind of experiential work with that. It might be just helping you, like a focusing exercise to help the therapist really understand what was going on for them in that moment. It might be a role play where they play out a conversation with their patient, and they could play their patient, like I did in my training experience. It was so helpful playing my patient. Or you could play yourself and somebody else in the group could play the patient. Or you could play both parts and move back and forth between the chairs. Sometimes in the process of exploring that, we'll realize there's some kind of inner struggle for the therapist. Like, do I do this or do I do that? Or I'm trying to do this, but I feel like I'm so ineffective. And you hear their kind of inner critical voice coming out. And we might shift a role play to being 2 parts of the therapist, kind of having a conversation, like your internal dialogue. And what we're trying to do here is just increase awareness of what's going on. And as you become more aware of what's happening, places where you felt stuck, you start to get unstuck. You start to see possibilities you didn't see before. You might come across something that you're like, oh yeah, I'm going to say that to my patient in the next session. That could happen, but that's not necessarily the aim. Like, we're not having them rehearse what they're going to do. It's more like helping them see it differently, so they're now ready to go into their next session and roll with whatever happens, right? They're like feeling more capable and seeing more avenues that they could take the next time they meet.
Do you think that in going through this process that the therapists are better able to, in the moment, in session the following week or month or whatever, able to identify the ruptures as they're happening?
That is a hope, and we're always, like, with our research, trying to get better and closer to actually being able to, like, say that that's definitely happening, right? To use the right measures to get at that. But yes, I think with recognizing ruptures, there's both people sort of developing the skills to kind of see it. And this is where things like, oh, there's a withdrawal, there's a confrontation, those concepts can be helpful. So recognizing those markers, but then also, this is a big thing in AFT, is your own sort of internal sense that something's going on. So the more I'm able to realize what I'm feeling, then I can pick up on, oh, something's off. Like that might be the earliest warning signal of a rupture is I feel a little uncomfortable or anxious or disconnected or, whatever it is. So yeah, that's definitely a goal of the training.
This is what I was sort of preparing for this and thinking about this. That's exactly what came to my mind, is that it's that feeling, right? And that of course, this is just based on what was happening in my head, so I could be terrible at it. But it's like that feeling is the trigger of like, there's something going on here to pay attention to, and I need to quickly make some sense of it. I don't mean literally to fully interpret it, but like bring it into the room. Is it my own anxiety about something that, some sort of, kind of countertransferency kind of a thing that I don't need to verbalize it, but I need to think about, that intuition to like not talk about this thing is probably wrong. Like that sort of stuff. So I was thinking about that in terms of those, like that feeling is what, gets you going, in your head very quickly of like, what's going on here? What should I do about it?
Well, and maybe what's going on here, I think we can linger there for a long time, actually, because what do I do about it might bring with it a sense of pressure. So,
right.
Yeah. So I'm thinking it's more like, okay, let's just lean. I'm really curious. Let's lean into that and kind of follow that curiosity.
Right. Say more about that.
Well, I think part of what I think happened, what we hope to do in AFT, one of my colleagues referred to it as sort of destigmatizing ruptures. So therapists may come in thinking, okay, ruptures are bad and scary and I should avoid them at all costs. And if they happen, it's like a fire I've got to put out immediately. And we're trying to say, these are part of the process. It's inevitable that ruptures will occur. I'm not saying that every single rupture that occurs is inevitable, because I think there's some things we shouldn't do. There's some mistakes that we shouldn't make. But something of some sort is going to happen. And to like lean into it with curiosity. And if we're coming from a position of humility, like I contributed to this somehow, I'm part of whatever process is unfolding, and I'm curious about what's happening. And I think understanding this will help. If my patient and I can work together to understand this will help both of us and help the process. So kind of thinking about that, and like, as we lean in like that, then what to do will come more easily, I think, more organically.
Totally. So, so in the training that you do, where are folks in professionally?
Great question. So
typically, I guess.
For many years, we were working with advanced trainees. So like psychology interns, psychiatry residents. So people who we weren't teaching them how to do therapy, right? We were like bringing additional skills to people who already had some way of doing therapy. And we've recently done some more trainings with people who are already licensed. So definitely already know how to do therapy. I think if we were going to do this work with somebody who's like literally it's their very first case, we would need to add things to it. Because we're really, it's important to me that it's not presented as a type of therapy. It's an approach to training that my hope is useful for anybody doing any kind of therapy. I'm not coming in here saying you can't do whatever kind of therapy you're doing. I'm not interested in being part of the therapy wars. It's more like, here's some tools and ideas that anybody could incorporate that I hope would be helpful.
When the idea of rupture shouldn't happen, that sort of unhelpful belief, do you see that a lot?
I see that I mean, it's often tied to also defining rupture. I mean, it gets tangled up in how people define ruptures. So somebody could probably define ruptures in a way where we'd all be like, yeah, that shouldn't happen, right? Everybody,
like a blatant argument with your client where you're just like going back and forth.
Or like I don't know,
like that.
Beating each other up physically or something. Like, yeah, that shouldn't happen. Agreed. But I think on maybe there's some people who might. I have heard some people say like, oh, in this approach or whatever, like we don't see ruptures, or we very rarely see ruptures because we're so good at this, that, and the other. And I mean, the way I define ruptures, I do see ruptures. I mean, I see ruptures everywhere, but that's because I am looking at these little more subtle things too. And then I think there are beginning trainees like who feel like I'm supposed to be perfectly understanding and empathic 100% of the time, and I'm supposed to always know what to do. And so every little misstep is terrible. And I, if I just work a little harder, then I won't make any of those ever.
I'm thinking about, as we're talking, I just talked to Dennis Kivlikan, who's a big group researcher, right? And so we talked about like group conflict, and that the value in having sort of that like increased group conflict during the middle stage, if you will, of group therapy, right? And that I'm also thinking about some of the work on like interpersonal complementarity, and that sort of this model of, again, sort of as you get into the real work of therapy, you have increased anti-complementarity, right? So like that tension is necessary and part of the process of change, because you're bringing in things that are going to push the client or pull the client, and they're going to do the same things back to you. Like that is regardless of orientation. And this stuff's been observed across orientations. And so that like to that, and I don't know, I'm curious your thoughts about this, but like that is sort of, this is a way of thinking about that ruptures are in some cases an indication of working, of doing hard work.
Yes, I think that is true. And I think one example that springs to mind is especially like when somebody who's been very withdrawn finally starts coming out of their shell, and maybe they come out in a slightly aggressive way.
Right.
Like I might code that as confrontation, but I'd be thinking, hey, that's good. That's progress for that person. My only hesitation is I want to be careful about going too far in the, oh, ruptures are good, that means I'm doing the right thing, because sometimes we can use that to be licensed to push too hard or to be too aggressive ourselves, right? Or to kind of like write off, dismiss things that might be warning signs. We're like, oh, this just means good things are happening. So I think I guess I like to be sort of like, we just have to be really curious. Whatever's happening, it could be good, it could be bad. We can't like assume we know what it means.
Right. Yeah. And I think maybe an amendment would be that ruptures and repairs are an indication of working. Like the two happening together.
Yeah.
Right. That if I totally disregard, that's overstating it. But if I become brazen, right, because so I just like push super hard, like, then that sort of indicates I don't care that much. So like repair is probably not going to happen because I just think it's okay and ruptures are fine and we're just going to keep going. But if I, am able to find that, the zone of proximal development or whatever, like to push some, but then also to like work through that with my client, that's an indication of working.
Yes. I think that's well put.
Okay. So where do you think that, and so I'm sort of curious about your own sort of experience in training and working with lots of folks, like where do practitioners tend to miss ruptures? Like where do are there certain types of ruptures that you sort of see like, oh yeah, this is frequently missed?
I think generally withdrawal is more subtle and more challenging to recognize than confrontation. And actually when I present on this, that's also where I would get more pushback. Like some of the withdrawal examples, people will be like, well, that's not a rupture. And to be fair,
like what?
Like,
Go ahead.
let's say,
You can keep going.
Yeah, but well, no, like the very intellectualized patient. People will say, well, that's just how that patient is. And I'm like, well, you could say the same of the very hostile patient, but you're okay with me calling that confrontation. I still think that's withdrawal. That, to be fair, as we do more research with this, we may find that some of the ways we're operationalizing this, okay, maybe we're overcoding some things, or maybe we need to adjust some of that. But I think movements away can be harder to detect, and they can also include somebody being kind of deferential and appeasing, and that can be tricky because they're saying everything's great, and you're like, okay, great, everything's great, but everything's not really great. That can be challenging to pick up on.
Yeah, that's one of the things I talked to in my the class I just finished teaching is like, I don't know, where I always say that like if everything you say your client completely agrees with you, then there's something going on there. Yeah. Like because that just is not normal. Yeah. Like they have to amend some things and say like, yeah, mostly, but a little bit. If it's everything is if you're perfect, there's a problem because you're not perfect.
Yeah.
What kind of ruptures so that's in the identification. Are there types of ruptures that you think that therapists have the hardest time sort of responding to therapeutically?
Ooh, that's a good question.
And I have a related question, so they might be the same answer.
Okay.
Which is the types of ruptures that therapists tend to have the strongest emotional reactions to.
I was struggling to think like what's the answer to that, and I think it depends.
It always
does. But what I'm thinking is I think the answer may be a little bit different for every therapist. Right? Because it's also tied into us and our interpersonal styles and some people I've heard people say that withdrawal's really hard for them. They prefer a good confrontation where everything's out in the open and they know the patient's upset and it's clear. But then for other people, confrontation would freak them out or be really uncomfortable, and they would rather deal with withdrawal. And then there's subtypes within that. And I think also, ruptures that are tied to differences in identity and culture, I think those can be really tricky, or people can get very uncomfortable around. But I think the answer may be different for every therapist. And we also maybe just need more research to answer that question.
When you say rupture related to identity,
so I think
what does that look like?
I see you could have a rupture that, like, I think you could conceptualize microaggressions as falling within rupture if a microaggression happened in therapy, either the patient saying something against the therapist's identity or the therapist saying something against the patient's identity. I think there can be misunderstandings that arise due to cultural differences. And actually in like Chris has written about how you can understand all ruptures as being part of like two people with all their different identities and experiences kind of, clashing or having difficulty connecting. So you could sort of see all of ruptures being embedded within culture and cultural identities. But sometimes there are certain ruptures where it's more explicit that bias, misunderstanding, prejudice, something like that is a salient piece of the rupture.
Thanks so much for watching. If you enjoyed this episode, don't forget to like and subscribe, and be sure to check out the second part of this conversation. Until next time,